Hello again, my name is Kathryn Schlosser. I'm going to be discussing open ventral hernia repairs and penicillin allergy. These are our disclosures. Approximately 11% of the U.S. population endorses a penicillin allergy. However, when actually tested, only 1 to 10% of patients with a reported allergy actually have an IgE-mediated reaction. While literature in the 1980s posed significant concern regarding cross-reactivity of cephalosporins with penicillin-allergic patients, the incidence of true cross-reactivity has proven minimal. 0.5 to 2% of patients with a demonstrated IgE-mediated allergy to penicillin show any reaction to first or second generation cephalosporins. Third and fourth generations show a similar reactivity to the baseline population. The American College of Surgeons recommends the tailoring of surgical prophylaxis to the type of case and anticipated contamination. Cefazolin is the first-line prophylaxis in hernia surgery, with clindamycin or vancomycin recommended for penicillin-allergic patients. In contaminated cases, the recommended prophylaxis is dependent on the source of the contamination, but usually includes a beta-lactam and Flagyl. For penicillin-allergic patients, the recommendations vary for contaminated cases and can include clindamycin, gentamicin, or Cipro. Multiple studies have examined the consequences of reported penicillin allergy with subsequent administration of non-beta-lactam surgical prophylaxis. Non-beta-lactam prophylaxis is associated with higher cost, higher incidence of drug toxicity, contraction of drug-resistant infections, and higher rates of surgical site infections in orthopedic, plastic, and other general surgery cases. Furthermore, the multiple studies have demonstrated the safety of administration of beta-lactam prophylaxis to patients with reported penicillin allergy when they are appropriately screened. The goal of this study was to assess the impact of penicillin allergy on antibiotic choice and outcomes after open ventral hernia repair. For this purpose, we queried our prospective single-center hernia-specific database from 2007 to 2018, reviewed penicillin allergy as reported by the patient, as well as drugs administered and outcomes. We actually used a subset which had this data available from a subset review. We identified 1,178 patients with available information. The mean age was 59 years. BMI 34, 15% had a history of smoking, and 31% had diabetes. 22% of patients endorsed a penicillin allergy, with 56% reporting rash or hives, 15% endorsing airway symptoms such as wheezing or anaphylaxis, and 30% with non-specified reactions. Patients with penicillin allergy reported were significantly more comorbid. They were more likely to be female, on steroids, have asthma or COPD, to have sleep apnea, to have a history of MRSA, almost double the rate of a history of MRSA, and to have anxiety and/or chronic pain. We then examined patients, 22% of patients with a reported penicillin allergy did receive a beta-lactam prophylaxis with no adverse reactions reported. 38% of patients with a reported penicillin allergy received vancomycin, and 36% received clindamycin. I'm going to pop back one slide. There was no difference in defect size or history of recurrence between groups. However, patients with a history of penicillin allergy were significantly more likely to have a contaminated case, with 13% presenting with an existing mesh infection and 7% presenting with existing fistula. We then examined patients by wound contamination and administration of beta-lactam prophylaxis. In 683 patients without a history of MRSA with clean cases, 82% received a beta-lactam, of whom 96% received ANSEF. Of the non-beta-lactam prophylaxis, 45% received vancomycin and 49% received clindamycin. In this cohort, patients who received a non-beta-lactam prophylaxis were more likely to need percutaneous drainage for seroma. There were no other differences in measured outcomes. In 117 patients without a history of MRSA with clean contaminated cases, 82% received beta-lactam prophylaxis, 70% of whom received ANSEF. In patients with a non-beta-lactam prophylaxis, 70% received vancomycin and 35% received clindamycin. We then examined patients without a history of MRSA with contaminated or grossly contaminated cases. 34% of grossly contaminated cases did not receive a beta-lactam, of whom 63% received vancomycin and 33% received clindamycin. We found that in grossly contaminated cases, patients who did not receive a beta-lactam had higher rates of wound complication, reoperation, and recurrence. Finally, we examined patients with a history of MRSA. 45% of these cases were contaminated compared to 26% of the total population. 61% of patients with a history of MRSA received a non-beta-lactam, of whom 81% received vancomycin and 10% received clindamycin. We found that in patients with a history of MRSA, receiving a beta-lactam prophylaxis was associated with significantly higher lifetime readmission rate. We then performed a multivariate analysis controlling for factors found to be different between patients with and without penicillin allergy. This included administration of a beta-lactam prophylaxis, defect size, sex, diabetes, COPD, and asthma. In clean contaminated cases without a history of MRSA, we found that beta-lactam prophylaxis was not associated with any adverse outcomes. In clean cases. In clean contaminated cases without a history of MRSA, we found that beta-lactam prophylaxis was associated with a lower all-time readmission rate. In contaminated or grossly contaminated cases without a history of MRSA, we found that beta-lactam prophylaxis was associated with lower rates of recurrence and reoperation. Finally, in patients with a history of MRSA, we found that administration of a beta-lactam prophylaxis was associated with increased readmission rates at 30 days and neared significance for lifetime readmission for hernia-related complications. Based on this review, we can conclude that patients with a penicillin allergy are more comorbid with higher rates of MRSA. We found that the administration of a beta-lactam prophylaxis had no impact in outcomes after clean open ventral hernia repair. In contaminated cases, non-beta-lactam prophylaxis was associated with higher all-time readmission, reoccurrence, and reoperation. In patients with a history of MRSA, a beta-lactam prophylaxis was associated with higher rates of readmission. Moving forward, we can look at prophylaxis as dependent on the type of contamination for a case. In clean cases, you can consider testing for penicillin allergy, and the alternative would be vancomycin or clindamycin. In contaminated cases, for non-penicillin allergic patients, coverage should include ANSEF per the ACS guidelines. However, in penicillin allergic patients, we should be strongly considering confirming or testing for true penicillin allergy, as alternative administration of antibiotics can have adverse outcomes. Finally, in MRSA-positive patients, coverage will be specific to the source. Vancomycin is the first-line recommended surgical prophylaxis. However, some data suggests that ANSEF has better coverage for MSSA and may be considered in addition to vancomycin. Thank you very much. I'll take any questions.